Hello, I am Dr. Sarah Mangles. I'm a consultant haematologist and I currently am Clinical Director of the Southern Haemophilia Network and Centre Director at Basingstoke Comprehensive Care Centre. I'd like to thank the Haemophilia Society for asking me to talk today, and I'm going to be discussing mild and moderate bleeding disorders, particularly looking at how might it affect my life. I think this is a really important topic. We know that many meetings will discuss lots about severe bleeding disorders, but actually less patients have severe bleeding disorders than have mild and moderate. In our own centre, for example, we have around 120 to 150 patients with severe bleeding disorders, but we have nearly 800 patients registered with mild and moderate bleeding disorders. These are my declarations for this meeting. Obviously, I've had no support, but I have had meetings and support from various pharmaceutical companies for speaking and talking, and I'm also on the steering committee for Project Phoenix. So what am I going to try and cover today? Mild and moderate bleeding disorders are quite a large topic because they encompass a huge different variety of diagnoses, but we will look in general at the general characteristics, a little bit about how we diagnose things, types of bleeding disorders that might fall into this category, some of the challenges of having a mild or moderate bleeding disorder. We'll move on to the care and treatment, looking at the team who might be involved and what your care might look like, and then a few specific topics about living with a mild or moderate bleeding disorder, such as holidays, school and childcare, and something about changes with age. So the first thing to think about are what are mild and moderate bleeding disorders, and what do we really mean by this? So first of all, I think we have to look at the characteristics of a mild or moderate inherited bleeding disorder. The first thing to say is that there's no single definition of what makes something mild or moderate, and there's certainly no standardised definition in most bleeding disorders. In general, it's based on the severity of the bleeding symptoms, sometimes called the phenotype, which you may hear in a clinic. So we'll look at how severe someone's bleeding is and make a decision as to whether it's mild, moderate or severe. Certain conditions do have specific definitions. We know that mild and moderate bleeding disorders may be diagnosed later in life, and we also know that we may see different types of bleeding depending on conditions. The types of bleeding that we often see in mild and moderate inherited bleeding disorders are easy bruising or swelling after injury, such as a twisted ankle. So obviously if someone twists an ankle without a bleeding disorder, they may well get swelling and bruising. But if you have a mild or moderate bleeding disorder, this may be worse. Patients may have nosebleeds, heavy menstrual bleeding, bleeding after childbirth, bleeding after dental extractions, and bleeding after surgery operations. So some of you may wonder how we actually diagnose bleeding disorders. The first thing we'll do if we see a patient with a possible bleeding disorder is to take what we call the history or the story. What we're looking at is what symptoms of bleeding does a patient have? Do they just have bruises? Do they have nosebleeds? Or have they had more serious bleeding after an operation? Or is it just an abnormal test that the GP's done? When we ask about the symptoms, we might ask about the need for hospital admission, treatment with iron, and even blood transfusions. We're also going to ask about family history, so siblings, parents, aunts and uncles, to see if any of them have got any symptoms or even a known bleeding disorder. We may then go on to examine our patients. We might look for bruises or any other signs of bleeding. We may also look at joints to see if there's been any bleeding into joints, although this is more common with the more severe bleeding disorders. And then as a haematologist, one of the most important things will be the blood test. This allows us to measure the different clotting factors or to look at how the platelet count is or even how platelets are functioning. So moving on, what are the different types of mild and moderate bleeding disorders? So haemophilia, both A and B, is divided into 3 categories, and this is probably the only disease that has a more specific classification for mild, moderate and severe. So for patients with severe haemophilia, the factor levels, whether it's factor 8 for haemophilia A or factor 9 for haemophilia B, will all be less than 1. For moderate haemophilia, the factor levels will be between 1 and 5, What's really important to know though is that some patients with moderate haemophilia may have a severe phenotype or severe lots of bleeding, but the levels would still say they're moderate. And then mild haemophilia, where the factor levels are greater than 5. The normal factor VIII level in someone without haemophilia is between 50 and 150. But I think what's really important about mild and moderate bleeding disorders is it's not just haemophilia. We need to think about patients with von Willebrand disease. We need to think about people with platelet function disorders. And we also need to think about patients with the rare factor deficiencies, such as factor 11 or factor 7 deficiency. For haemophilia A, I've already explained briefly about the mild, moderate and severe. And some of this is around the types of symptoms that people will have. We know that for patients with severe haemophilia, they will have spontaneous bleeds. They'll also have traumatic bleeds and bleeds after surgery or dental extraction. And for these patients, they will be on prophylaxis. This will normally start before or around the first birthday and is preventative treatment using medication to prevent bleeds. For moderate haemophilia, some of the patients, as I mentioned in the last slide, will have a more severe bleeding phenotype, so they may also have spontaneous bleeds. Again, they'll have traumatic bleeds and bleeds after surgery or dental extraction. Therefore, what this means is that for some patients with what's classified as moderate haemophilia, they actually have a severe phenotype and therefore will be on prophylaxis. And this is certainly what's recommended in the newest guidance, both from World Federation of Haemophilia and the UK CDO. Other patients who don't bleed very much may be treated on demand or as needed. In mild haemophilia, we do see traumatic bleeds. The level of trauma tends to increase the higher the levels are before it causes a problem, but patients may also have bleeds after surgery or dental extractions. Again, treatment for these patients would be on demand or as needed. I'm not going to go into the specific treatment of each individual condition, as I think that's too complicated, and it's something that you can go back and talk to your teams about if you have any questions. We know about von Willebrand disease. This is a disorder that means that the von Willebrand factor is low. It tends to cause skin and mucous membrane bleeding, such as bruises, nosebleeds, and heavy menstrual bleeding. There are various different types, and I know there's a whole lecture on von Willebrands today, so I'm not going to go into great detail. Generally, there's 3 types, type 1, type 2, type 3. Type 1 is the most common. Patients have slightly low von Willebrand factor activity and may have a low factor VIII. Type 2 is where the von Willebrand factor protein doesn't work properly, and there's various types, type 2A, type 2B, type 2M, type 2N, and then there's type 3, which is the most severe, where there's virtually no von Willebrand factor, and many of these patients actually will have a severe bleeding disorder and will be on prophylaxis. What about platelet disorders? So this again causes skin and mucous membrane bleeding, and there's lots of different types. If you have a platelet disorder, make sure you know what type you have, talk to your own team, but some of the examples might be Bernard-Seilier, Glanzmann's thrombocythemia, although this may be more severe than mild, platelet function disorders, platelet storage pool disorders, and also MYH9 associated disorders. As I've mentioned before, the other clotting factors may also have low levels, and these rare factor deficiencies may also cause bleeding problems. So this could be factor 11, factor 7, factor 10, factor 13, prothrombin or factor 2, and also fibrinogen, where patients may either have low fibrinogen levels, hypofibrinogenemia, or dysfibrinogenemia, where the fibrinogen doesn't work properly. One of the things I think that we have to think about are the challenges of having a mild or moderate bleeding disorder. As I already said at the beginning of this talk, often meetings will only discuss patients with severe or a severe phenotype. They talk about the standard treatment and don't talk about mild or moderate bleeding disorders in the same way. Often patients have no problems day to day and wouldn't even know that they have a bleeding disorder until they either have an injury or perhaps have an operation or a dental extraction. What this does mean, however, is that often patients need help urgently rather than being able to help themselves, and they're also not able to self-treat. Because they don't have the problems, which is great, they don't necessarily know the team at the Haemophilia Centre as well, so may not feel as confident picking up the phone and asking for advice, or they may not want to trouble them. And sometimes patients with a mild or moderate bleeding disorder may have less understanding of their condition. Now, I would say that the understanding of the condition is the responsibility of the healthcare professional team to make sure that people have enough understanding for what they need. But if patients attend less, then obviously there's less opportunity for education. So moving on to the care and treatment of patients with mild and moderate bleeding disorders. So this is a photo from the Wellcome Trust showing treatment in World War I, and obviously care has definitely moved on since then. So what should an inherited bleeding disorder team look like? So there is a national service specification, but it tends again to refer mostly to patients with severe bleeding disorders. However, the same team is there to support patients whether they have mild, moderate or severe bleeding disorders. So with the patient absolutely at the centre of all care, the core team will be the consultant haematologist like myself, a nurse specialist or clinical nurse specialist who will have huge amounts of knowledge, will be able to treat patients, will be able to help with education, will go out to schools to do visits, will do home visits and support people going through operations. We also have the physiotherapist who normally is a musculoskeletal specialist who is able to help with joint problems or perhaps pain. And then we also should all have a clinical psychologist. And a psychologist is there to help patients when perhaps having a long-term health condition and then something else means that they are struggling. In our clinic, for example, this core team would sit in the main clinic for those with a severe bleeding disorder, but all patients with bleeding disorders would have access to them. The other thing to think about is who else might be involved in a patient's care or in your own care. And it's not just this core team. Really important people to think about might be your GP, who will be doing health prevention work, maybe checking your blood pressure, and you may have questions about whether certain medication is okay, and you can always call your team and check. Your dentist, it's fine to go and see a normal dentist for checkups, but if they want to do something, they might need to liaise with the centre team. There may be other doctors involved, such as obstetrics and gynecology if someone has heavy menstrual bleeding or is pregnant, ENT for nosebleeds. And then the other thing to think about is for children, who else might be involved? It could be school or nursery, a play therapist to help us do the bloods. And then in certain circumstances, a social worker or an occupational therapist may also be involved in care. Some people ask me what will care look like, and obviously depending on your centre may depend a little bit what it looks like. For us, our adults have annual follow-up. Sometimes those with more moderate conditions will be seen more often, perhaps every 6 months. Most of the time this is done as a telephone follow-up now, and it's often done with one of our clinical nurse specialists. Some centres would like to alternate face-to-face with telephone or even virtual, which many centres are starting to develop after COVID. Or some centres like our own will try and do a face-to-face clinic every 3 to 5 years. At this point we can recheck bloods and do height and weight and things like that. If it is just a telephone or virtual follow-up, don't be surprised if the team may ask you about your weight. This is so that we've got an up-to-date weight in case we need to calculate treatment doses. What about children? So again, for most children with mild bleeding disorders, follow-up will be annual. It might be that some teams, including our own, might see you more frequently when you're first diagnosed, just to help you understand what you need to about the condition, but after that follow-up becomes annual. Some may be face-to-face every year, or some centres like our own are switching to alternating between face-to-face and then the next one being telephone or virtual. But what we do ask is if they were doing a telephone or virtual clinic, that actually the child is present. So it's still a doctor's appointment, and it's important that the children are there because that's part of the education, so that they learn about their own bleeding disorder. So the question could be, what's the point, or why should patients have regular follow-up? Well, I see that the clinics are a time for education for newly diagnosed patients to make sure they understand. We know that prevention is better. We also know it's better to have regular contact and remind people about the team, so that if there is a problem, they know who to contact. It does ensure that patients or parents and carers are up to date with how, who and when to contact the centre team. And if there have been any changes, or the centre's moved or changed locations, then those telephone calls can be really useful. It's also really helpful for patients and parents and carers to know about the services available to them and remind them about access to physio or psychology. And this does change over time. As a doctor, it's actually really much easier for me as well if there's an up-to-date letter on the electronic patient record. This goes both to the GP and stays on our records. And it means if we get a phone call in the middle of the night, that letter is easy to find. We can work out what treatment is needed. We also know that IT systems change and old blood results may not be visible, and that's where it can be really helpful to have current letters on the system. So what can patients with mild and moderate bleeding disorders do to help themselves? I would say ensure you have an up-to-date bleeding disorder information card. All of you, if you're registered through the National Haemophilia Database, should be able to get one of these. You can have more than one copy. They look like this at the bottom. They're printed onto paper, and then you can stick them so that the information doesn't rub off. They do look a bit flimsy, but they are the official card. I always recommend that patients take a photo of it as well on their mobile phone, so that if they haven't got their wallet with them or they lose it, that information is there. On the card itself, there's also the contact information for your local service or where you're registered, which can be useful if you don't remember. The other thing that's really helpful is to save the Haemophilia Centre contact details to your mobile phone. Many of us won't remember mobile numbers or phone numbers anymore, so if it's in your phone, it's easy to find in an emergency. If you do see another doctor or a dentist and they talk about needing a procedure or an operation or taking a tooth out, please don't presume that they'll contact us. Some are brilliant and will, but not all of them will do that. And they won't all have an understanding of the bleeding disorder and what's needed for treatment. So it's really important that if you go and see another doctor or dentist, contact us and let us know. I would always much prefer to hear about something happening from both the patient and the surgeon than only finding out about it the morning of the surgery and then not knowing about it and having to delay surgery because we haven't got a plan in place. Obviously, it's really helpful if you attend appointments. If you can't attend, just pick up the phone and tell people that you can't make it or send an email in, and then appointments can be rebooked. So what about living with a mild or moderate bleeding disorder? Some specific things to think about. So obviously holidays have been a little bit different over the last 18 months, but hopefully in the next year or so, more of us will be able to travel abroad. So if you're thinking of travelling and it's been a little while, talk to the team at your centre. They know specifically about you and your bleeding disorder. But things to think about are, have you got up-to-date travel insurance? Does it cover your bleeding disorder? And it's really important that it does. Do you have a travel letter? So when we talk about a travel letter, this is a letter that describes your condition and your usual treatment, and often has the contact numbers for the centre on so that people can phone if there's an emergency. Some of you may need to take some treatment with you, so perhaps tranexamic acid, the medicine that stops clots being broken down and is often used for heavy periods and nosebleeds. So if you've got some of this and are going to take it with you, make sure it's in date and you've got enough. Some patients may even have a dose of factor if they've, say, got moderate haemophilia and they're going abroad. It may depend where you're going and where the nearest haemophilia centre is to where you're going. It's now possible to look up online through both the World Fed and EHC for the closest centre. If you're a patient who's registered on HaemTrack, it's also possible to look up all the UK's closest 3 centres in the UK on the app as well. And that can be useful. If you're struggling to find your nearest centre to the holiday, talk to your team at the Haemophilia Centre, and they're always happy to help. Also, a point for sort of teenagers who are starting to think about travelling on their own or without family members, ensure at least someone you're travelling with knows about your condition and where to find the important information in case there's an accident or someone needs support urgently. What about school and childcare? So I think it's really important that nursery childminders or schools are aware of the diagnosis. Some will want a documented care plan, some are happy just with the name of the diagnosis. Things to think about are, is there any need for medication or treatment to be at school? Depends where the school is, maybe compared to home. I think really important is to remember that first aid is first aid. So if a child falls over in the playground and grazes their knee, the school need to do normal first aid first. And only after that might they need to think about something else. The haemophilia nurse specialists are brilliant at this and are always really happy to help. It might be going through it with you as a parent or carer, just so you know what to say, or if the school are phoning for every single knock and bump and this just feels too much, then the nurses are always happy to give talks to the teachers. With COVID, one of the benefits has been the nurses giving many of these talks via Microsoft Teams or other virtual platforms, which makes it so much easier, both for many of the teachers at the same school to attend, but also for the nurses who aren't having to travel in the same way to all of the different schools. There's also some really helpful information booklets from the Haemophilia Society, which can be left with the school. A specific thing to think about is PE at school. It's really important, firstly, that actually children take part, play with their friends and stay fit and healthy. And that's where we should always start when we're thinking about children and their bleeding disorder. Encourage them to find something they like, maybe try different sports. For those in junior school, to be honest, but certainly for those with mild and moderate bleeding disorder, I wouldn't have any concerns about the normal PE. It's often jumping, running and things. As children progress to senior school, there may need to be some limitations, and therefore definitely talk to your team about what's okay and not. Again, if there are challenges, or perhaps the PE department are stopping your child from joining in, saying they have to stand on the touchline and just watch, or just not enjoying it, talk to the team again. Our physiotherapists can talk to the PE department and explain in more detail both the importance of exercise for our children with bleeding disorders, but also what's okay and what's not, and give the PE staff the confidence to let children join in with sport. A brief comment about COVID and the vaccination. So many of you may have already had the vaccine and know what's been going on, but for those of you that aren't or have got questions, there are national guidance. There's national guidance in what's called the Green Book, which is the National Guide to Immunisation, and that's actually available for everyone to read on the government website. And what that has said is, after the trials, when the COVID vaccine was given as an intramuscular injection, after a discussion with lots of different doctors, it was felt that individuals with bleeding disorders could be vaccinated intramuscularly. Now, some of you who've been around for longer may have heard, oh, you can't have an IM injection, but actually our understanding is starting to change. So now if you have a mild or moderate bleeding disorder, you can have an IM injection without treatment. If you have a severe bleeding disorder or on regular treatment, you need to have that on the day or close to when the immunisation is due. Interestingly, since the COVID vaccination has gone IM, the flu guidance has also been updated, and now this can also be given IM for those of you who are eligible for the flu vaccine. So this article at the bottom has recently been published in October by the teams from the Bristol and Oxford Haemophilia Centres, and looked at the experience of COVID-19 vaccination in patients with bleeding disorders. They sent out a survey to patients and have collated all the results. This data is taken from there. What you can see is that 86% of patients who'd completed the survey and who'd been vaccinated against COVID had no bleeding complications. About 8% had bruising, 4% had mild swelling, although it's important to know that some patients without bleeding disorders did have mild swelling too. and 2% of patients had bleeding. Now 2% of patients was actually only 3 patients, and they reported bleeding complications not at the site of the injection but at a site away from the injection. So interestingly, all 3 patients reported heavy menstrual bleeding, and interestingly all 3 of those patients also had an unclassified bleeding disorder. Now an unclassified bleeding disorder is one where laboratory tests haven't given us a specific problem, so they haven't diagnosed haemophilia or von Willebrand or a platelet problem, but the patients have a really strong bleeding history, so have had lots of problems with bleeding. And so when we think there is a problem but can't find an exact cause, it becomes an unclassified bleeding disorder. What's also important in the 8% or so who had bruising is that over 65% of patients applied pressure for less than 5 minutes. And the World Federation of Haemophilia advised patients to press on it for a minimum of 10 minutes if they had a bleeding disorder to prevent bruising. One question we sometimes get asked is, do bleeding disorders change as we get older? So interestingly, some clotting factors do increase as we get older, so perhaps patients may have some less bleeding, but some will stay the same. And I think in this talk it's too difficult to go into the ins and outs of each different bleeding disorder. What is important as patients and people get older is that other illnesses start to happen, whether this is high blood pressure, high cholesterol, diabetes, arthritis or cancer, and all of those may need treatment. Really important that just because you're under the bleeding disorder team, you don't ignore GP and the NHS health checks that are recommended. And if something is diagnosed and you've got any questions or concerns, whether this is about a new medication that a doctor wants to start or a more complicated problem where you maybe need an operation or more treatment, please do talk to your inherited bleeding disorder team. We can liaise with the GP or the specialist. Having a bleeding disorder won't stop treatment, but it may need more careful planning. So it's really important that you talk to us. So if you have a mild or moderate bleeding disorder, please ask your team questions if you don't understand. I always say there's no such thing as a right or wrong question or answer, and ensure you know enough about your condition. Know how to contact your team and who you have access to. So maybe you should and hopefully do all have direct access to physio and psychology. The other thing to remember is tell other healthcare professionals about your bleeding disorder before they do anything, but understand that they may not know very much about it. You are likely to be the expert. In medical school, often there is a single hour on bleeding disorders in lectures, and so you will become the expert very quickly, and so please remember that and then speak to the team once you know what needs to be done. So I hope that talk's been helpful, and I'm happy to take any questions.